Well, hey everybody, it's Sandy and welcome back to my channel dedicated to helping you advocate for your own health, one topic at a time. Today, guys, I'm very excited because I have with me Dr. Dersley, and some of you already know that he is a frequent and valued contributor in the Sandy's DIY Health Advocacy Facebook group. And if you don't mind, I'm just going to give that a quick plug. So if you like my content and you want something in addition to that that's a little more of an interactive forum, head on over to Facebook. Sandy's DIY Health Advocacy has a Facebook page and you can ask to join the group. Dr. Dersley is a dentist, and I think you practice in Virginia, Maryland?
In Maryland. Yeah.
Okay, in Maryland. So I'm going to let him briefly introduce himself, and then we're going to talk a little bit about overall dental hygiene, dental health, and then what's changed with COVID and other such. So just keep watching.
Okay, thank you, Sandy, and thanks everybody. Yes, so I've been a dentist for almost 20 years now. I'm actually a prosthodontist, which is a specialty area of dentistry. We do a lot of replacement of teeth. So when people are missing teeth, we do implants, we do dentures. So my patient base tends to skew to the older segment of the population. And I do practice in a general practice. So I have partners who are general dentists.
And can you tell us a little bit about your training, your background, what brought you to, did you practice general dentistry first?
So I went to dental school after college. I went to Columbia University up in New York City. That's a 4-year program. And then once you finish dental school, there's an option to practice as a general dentist or to go into a specialty area. So some of the more commonly known specialties like orthodontics, endodontics is root canals, you have pediatric dentistry. The specialty I chose is prosthodontics. So we're generally fixing broken things, replacing missing things. The residency program is 3 years after dental school. So I did that at the University of Maryland.
Okay, so we have a common alma mater. What years were you at Columbia?
Columbia, 2000 to 2004.
Oh, you're a little younger than me. Okay, so maybe, can you tell us, we get a lot of conversation in the Facebook group. I think one of the things, at least as far as COVID consciousness is concerned and people who are risk adverse are concerned, one of the scariest things is going to the dentist. So I thought maybe you could talk to us a little bit about what's changed since COVID.
Sure, yes. So, definitely it's striking that balance, right? Because we want to maintain our health. We don't want to forego medical appointments. That can be detrimental. So I know a lot of people have had some nerves about going to the dentist. I guess, as far as risk factors go, it'll depend on the office environment. Many dental practices tend to be a little bit different than like a large volume clinic. Most of the offices I've worked in, we try not to have a lot of patients in the waiting room. Generally our scheduling philosophy is try to have a room available right when the patient arrives. So they can come in, they just check in, and we pretty much immediately take them back to their room. Fortunately, our office was designed pre-COVID, but it just worked out. Each room is individual. So there's walls between each room, doors, which turned out to be nice for, privacy, but also for, in COVID, our patients who are a little more concerned, like the fact that they have their own little room there. I know a lot of offices tend to be a little bit more of an open floor plan. And some of those offices have adapted, put little dividers between the chairs at least. Dentistry, before we still had a lot of protocols in place as far as infection control. There's a lot of other things that we protect against, TB, hepatitis, HIV, we don't want any diseases spreading in the dental office. So as far as surface contamination, TB is one of the toughest ones to contaminate or to disinfect. Our protocols that take care of that are more than adequate for COVID as well. Instrument sterilization, same thing. So it's really more about the air that, that's what's changed since COVID. So most of our previous protocols have done very well for the pandemic. We haven't had to really adapt those much. It's more about just giving the patients a chance to have the distancing that they would like to have. As far as the air quality goes, having good ventilation just in general is good. But then the, air purifiers and things like that.
That's a really good point you bring up, and thank you, about TB, because I think that doesn't really get enough attention when it comes to surface decontamination. If you're doing certain things, I kind of remember this when HIV was fairly new, and there was that fear. And the truth was, if you washed hands and you sterilized instruments and things like that, it was just like with COVID, that as far as surface contamination goes, it's those same protocols should take care of that. But like you said, people are really concerned about aerosols now. I know you use, maybe not in prosthodontics, but in the general dentist's office, at least, they're using like Cavitron machines that make all kinds of aerosols. And is there anything being done differently these days, or how is that handled?
So it's interesting because, that especially in the very early days, in April, March of 2000, we didn't really have any data. And there were a lot of concerns and predictions that the dental office would be one of the most unsafe places you could possibly be because of all the, the aerosols, not only from the ultrasonics, but the hand pieces we use when we do treatments. There's the generation of those aerosols. There was actually an article that the dental hygienist was the most dangerous profession. And this was in, I think, like April of 2020. And the article came out when most practices were not doing any dental hygiene. So, my office, we had to do only emergency procedures for 6 weeks, during the shutdown and everything. And so the hygienists, they were kind of at home reading these articles, and they were, and on Facebook talking about these articles, and they were just so concerned, and, I think, rightfully so, but fortunately, it turned out they came back to work, and we had, the job of dental hygienists didn't change, right? The things they need to do their work is the same. We had, they were wearing, they changed the masks that they wore. They're wearing face shields, but other than that, they're just doing basically the same job they did before. We did notice that extra protection seemed to be adequate. We weren't having a lot of cases among dental staff. And I've seen some data that dental staff have had, actually, when one report came out, they had a lower infection rate than the general population, despite the occupational exposure. So that was good news for all of us. I think also good news for our patients, because if we are in that environment all day long and not getting infected at a high rate, it's an indication that it's not a super high risk environment. Now for the patient, right, so they're going to be taking their mask off during treatment. That's something that they are more concerned with in many cases. So we want to be sure of a couple things. One is that during that time, they're in an isolated environment, which in our practice, they're in their own little room. So that's good. Their main exposure is with the dentist and the dental assistant at that time. And so we want to make sure that we have our PPE in place to help protect the patient during that time. And that is the most important thing.
So is there any concern for that patient as far as aerosols that might have been elicited around the room from the patient before them? Or is that sort of just more superstitious?
I don't think we have data to show that that is a concern. At one point, the CDC required a 15-minute period between patients. So the room had to be just empty for that period. And the idea was that, most of the aerosols would settle. That was in place for a very short period of time. And then they reversed it. Now, I don't know why they reversed it. I don't know if they actually had data that showed that it wasn't necessary. I don't know if there was pressure, from the commercial side of things to take that away. But I do know that was eliminated. As far as any kind of, proof that that is a concern, I don't think there is. So it's more if a patient was really high risk and really highly concerned, one suggestion is for them to ask for an earlier appointment in the day. Then they're really the first person in the room.
Thank you. And then again, you're using a high quality HEPA filter with viral particle size filtration in rooms. And I take it, well, let me just segue then into the next thing. That might be one thing on the list. What might somebody look for when maybe they've decided that their dental practice is, too risky? Like you said, maybe it's a big open room without dividers or something, or you're just looking for a dentist or a prosthodontist or whatever it might be. And besides the clinical capabilities and good recommendations, what should somebody look for in terms of health and safety in the office, or what should they ask about?
So this is a tricky question because I think, super important, like you said, is to make sure overall it's a good dental practice. You want to make sure it's going to be high quality treatment. You want to make sure that their philosophies line up with yours. Some dentists lean more toward being more conservative with their treatment. Others are a little more proactive with recommending things. You want to be on the same page as far as all of that goes. You want to make sure that whatever financial policies the office has, you can live with. So all of those combined with an environment that the patient's comfortable with as far as COVID goes, it does make selection of an office a challenge. One of the best ways that I know of is through word of mouth. That's how we get most of our patients nowadays. It's just a patient will have a dental issue and their friend will tell them about our office and about the things that they like about our office, and then the patient comes to see us. So if somebody knows someone locally who has a dentist that they highly recommend, that is a really good starting point, at least. Then you can always call the office and ask any questions you might have. You can always go on their website. Sometimes there'll be information there that you can find. Like my office, we actually have an office tour on the website. So it's like, the street view for Google. It's the same thing for our office. You can actually navigate through the office and see what the setup looks like.
So in terms of mitigation strategies, are there specific, let's say I've found through word of mouth and I've checked the background and whatever, and all those boxes are ticked. And now I want to make sure that I'm going to be safe, like from an infectious standpoint. What kinds of things might I ask? I guess the first one is what we talked about. Are you using a filtration in the room?
Mhm. Yeah, you can ask about that. You can ask about, most likely, you're gonna talk to the receptionist, and they'll tell you that yes, the office follows all OSHA infection control procedures. I mean, by law, they have to anyway. They will, most places still, there's a mandate that medical staff will wear masks at all times. They'll tell you that they're following that. Now, I don't know if that's the case in all states still or not. I do know in Maryland, it is still a mandate for that, at least. But they may have additional protocols that they've put in place. So one thing to ask is, is there anything above and beyond that you do for COVID?
Oh, that's a good question.
Yeah. And then, just see what they say about that.
Yeah. Okay.
Yeah.
And then you can always ask for individual, can I wait in my car until you have a room ready? I think that any place should be willing to let you do that if you'd like.
Right. Yeah. And that's a good thing to ask to do. I still have some patients who really like that anyway, even though usually we don't have a wait in our waiting area. They just like to walk straight on in.
Right.
Yeah.
Okay. So let's segue off into, first of all, do you think that most of these mitigation measures, the things that have evolved since COVID, I mean, I think dentists were wearing masks before COVID, but there are a few other things that have evolved. And like, as you said, dividers and the HEPA filtration. And do you think most of these things are here to stay?
A lot of it, because the cost is upfront, I think so. I don't think there's really much reason. Now, some things like, we had a ton of plexiglass around our front desk, and we've removed some of that just because, data and studies have shown that it's really not the thing that's going to protect anybody anyway. And it did interfere a little bit with people communicating. So, some of those things aren't quite as intense as they were a year ago. But a lot of the things I think will be around for quite a while.
Okay.
If I had an office that was kind of open bay and I was designing a new office now, I think I would change that up a little bit. So maybe we'll see a change in the way that offices are built moving forward.
Yeah, I like the private room. I happen to just have that at my dentist's office, and I like it a lot.
Yeah. It has a lot of other benefits too. I mean, we can talk without having to worry about people overhearing. No one really wants to hear all the noise from the patient being treated next door anyway. So there's a lot of other benefits.
That's right. I agree. So what about, there's one question, this is a diversion here, but this has come up in the Facebook group a couple of times. And I'd like to ask you, first of all, about what you think is just the ideal, just oral health regimen, besides obviously the semi-annual checkups and things like that. But I mean, what people are doing at home and what they should be doing and what you'd like to see people doing better for the most part. And then I wanted to ask you about xylitol. We've talked a little bit about that in the Facebook group.
Sure. Okay, so if we look into the course of human history, up until modern times, people did not have as much trouble with their teeth. So you go back to the Stone Age, a dental infection may have been a mortal problem back then. There was no such thing as getting a tooth removed, because it was infected. So, but with a Paleolithic diet, it wasn't so much of a problem. They didn't have the sugar intake that we have nowadays, which is the main cause of dental decay, which causes the infections. So, if anyone is on a really low sugar diet, chances are they have a lower risk of dental infection and cavities, at least. The other main dental problem we tend to see is gum disease, periodontal disease, which is highly correlated with smoking. Not all people that have periodontal disease are smokers, but a high percentage of them are. And so if people, generally people who don't consume a lot of sugars, especially soda, and the two things that I see that are the biggest culprits are soda consumption and smoking. Avoid those two things and you're 95% of the way there as far as good dental health.
Wow, that's impressive. I would have thought it takes a whole lot more than that to be in maybe the upper 20th percentile or something.
Yeah.
Okay. What would you like to see people doing in terms of their oral hygiene care?
Okay, so oral hygiene, good brushing twice a day at least, 2 minutes per session. I had to really train my kids for a long time on brushing all the teeth, like inside, outside, all the surfaces. A lot of people just don't have that training. I've worked with patients in their 40s, 50s who are having problems, and I just ask them to brush their teeth for me so I can take a look. And you'd be surprised at the surfaces they're missing. It's not just the fact that you've brushed your teeth, it's the fact that you have cleaned all of the plaque off your teeth that makes the difference. Okay, so just being a little more thorough with it. Most people do well with an electric brush compared to a manual brush. Flossing once daily is recommended. If anyone notices they have bleeding of the gums while brushing or flossing, they need to brush or floss more. Is usually the problem. Okay. The patients who floss a couple times a week may have some bleeding there. And I just tell them, work through the bleeding, don't floss less because of the bleeding, floss more. And you'll probably notice you'll have less of that.
Yeah, to toughen it up.
Right.
Floss before brushing or after brushing, or does it matter?
I don't think it's critical. Doesn't,
Okay.
shouldn't take up mental space on that one.
It's like the toilet paper roll over or under, right?
Oh, over, definitely.
Okay, that does matter, but not when you floss. Okay. And then what about oral rinses, and including, if you could mention, well, let me just preface this. We've talked on the Facebook groups page about xylitol is actually an artificial sweetener. So you could use it in cooking or baking, I guess, and it will offer sweetness just like sugar does without the added problems of like dental decay. But there are actually oral rinses. In fact, I use one that is a xylitol rinse. So I was wondering if you could address oral rinses in especially that one.
Yes. Okay. So xylitol, there are some studies and indications that it may help with some enzyme, like to break down plaque. It's one possible effect from xylitol. It's not completely well understood. Fact is that most of that effect you can still get with good brushing and flossing. Okay? So a patient with really good oral hygiene and really good diet, I don't think it's going to move the needle much anyway, whether you do xylitol. But it's certainly not going to hurt. If you have a rinse that has it that you enjoy anyway, it may provide some level of benefit. Another component that we look for is fluoride. Fluoride does have a protective effect against cavities. Patients who are high risk for cavities, so if I notice they have a lot of fillings or crowns in their mouth from previous decay, if I notice they've had active cavities in their mouth in the last year or even currently, then having a fluoride supplement can help lower their risk for that. So there are mouthwashes that have a fluoride in them that are good for those patients. The patient who's already low risk, again, it's not something that will make a big difference.
So that's interesting about fluoride, because I noticed that when my kids were little, my kids are already in their mid and late 20s, but they were doing something that wasn't done when I was a kid, which was once a year, they put that fluoride treatment right on the teeth at the dental checkup and said, don't eat for an hour. And of course, that was the 1 hour they just wanted to eat. So,
Yes.
my kids never got cavities, and I'm quite sure that as much as I was a stickler about oral hygiene, that they weren't always brushing well as children. And I wondered, aside from an insurance issue, why don't they offer that to adults? Like I had a lot of cavities as a kid, and I have impeccable oral hygiene now, and I always get great checkups. But I thought, wow, 20 years ago, I would have liked if somebody noticed that and offered me, even if insurance didn't pay for it. Is there a reason we don't put those on adults?
Oh, sorry, Sandy, that cut out there just a minute.
Yeah, you froze too. So
Yeah.
I just wondered, is there a reason that we don't offer to put that fluoride treatment on adults' teeth?
Mm-hmm. So the adults in many cases can benefit from it more than the children can, because a lot of adults have previous dentistry that they need to protect. Okay. The main reason is financial, because insurance pays for the kids and not the adults. So, most dental offices will automatically do it for the kids with the parents' permission because it's covered under the policy. A lot of times it'll be recommended for the adult, but it'll be maybe about a $30 to $40 cost to do it. Okay.
That sounds like a good $30 to spend, or $40.
Yeah.
I'm going to ask about that next time I go.
Okay.
In.
Yeah. It could be. And so I think what happens is that, the hygienist or the dentist has recommended it, and it's so often the patient just kind of like, oh, it's an upsell, no thanks. Like they see it that way, and they just get so tired of it that they kind of stop recommending it.
Yeah.
Unfortunately.
That happens in general, in medicine in general. Sometimes we get so stuck in the rote acting in terms of what's the insurance paying for, that we forget that our job is to really talk to the patient about all the different treatments. When they sign the consent, it says, I've discussed all the alternatives, and really doesn't have anything to do with what the insurance would pay for. But a lot of times that's forgotten.
There's also the perception that if it was important, insurance would pay for it.
Yeah.
Which that's not really the case.
No.
Yeah.
All right. So I thought I'd just give you a moment if you wanted to, if there's anything I didn't ask or cover, or anything you wanted to talk about at all.
I think you've done pretty well. I think I wanted to cover also just with dentistry as far as treatment recommendations go. Usually when a dental problem is first starting out, it's easier to treat. So if someone has a small cavity and we notice it during a checkup, it may not even be to the point where the patient is aware of it. It might not be causing sensitivity yet. However, that's the best time to treat it because it'll probably involve just a small filling, very little chance of it affecting the nerve of the tooth and proceeding to more involved, expensive treatment, like needing a root canal or even an extraction of the tooth. One difficulty with that is that because the patient is not yet aware of the problem, oftentimes they may not associate that with the need to treat it yet. Many people have the idea that if it's not bothering them, don't fix it. And that it's better to wait until a tooth might become sensitive or fracture before going for treatment. The downside of that is that usually at that point, it's too late to do the low invasive treatment. I get patients all the time who call and they say, my tooth needs a filling. And they come in and it needs an extraction or it needs a root canal. Usually by the time they're aware of something being wrong, it progressed beyond that point, unfortunately.
Okay, so prevention is first. Next would be early intervention, early treatment.
Yeah.
Those are really important things in dentistry.
Yep,
yeah.
For sure. Okay. The toughest cases are the ones that I see where the patient, and unfortunately this relates with dental anxiety, where a patient may have been avoiding treatment for many years, even though they know they have problems. And it can get to a point where now these problems have compounded and it's just an overwhelming problem in their life. They have pain, they have social embarrassment, they have loss of function. And now we're talking about doing dentures, implants, all those things costing tens of thousands of dollars.
Mhm.
So, those are the situations we want to avoid, possibly through, like you said, prevention and early treatment.
Right. Okay, so I'm going to say a goodbye together so we can say bye, but don't click off because I want to say something to you after. Okay, so
Okay.
splice.
Yeah.
Okay, well, Dr. Dersley, I really want to thank you so much for taking the time. I know that people are really looking forward to this interview, and I know that I have found this incredibly helpful. You're a very valued member in the Facebook group, and I thank you for that as well. And it was just really lovely having you.
Thank you, Sandy. Nice talking with you.
All right, take care.